Dr. Osamu Ukimura pioneered the world's first application of augmented reality image fusion of three-dimensional ultrasound with CT or MRI and four-dimensional navigation technologies in urology. What did I just say? When I read that, I wasn't real sure what I said or what I read, so I had to go back. Let me repeat it again, kind of sink in a little bit. Dr. Ukimura pioneered the world's first application of augmented reality image vision of three-dimensional ultrasound with CT or MRI, and four-dimensional navigation technologies in urology. I'm still not sure what that means, but I'm sure Dr. Ukimura will mention it later on as we go through. He is also internationally recognized for his experience in the management of lower urinary tract dysfunction and laparoscopic surgery. At USC, Dr. Ukimura has built the country's first dedicated center for image-guided surgery and focal therapy. Focal therapy, that's the important part of this, we'll get into that. His team's cutting-edge research is developing innovative, new, high-precision focal therapies for prostate cancer. Unlike radical prostatectomy, where we cut out everything, including some nerves and blood vessels, if we can get this focal therapy developed and down to a science, it's going to be a great advance over what we have right now. These techniques aim to ablate only the dominant cancerous area while maintaining the rest of the prostate intact. This novel focal therapy approach will likely provide select patients with organ-confined, low-risk prostate cancer unparalleled continence and potency outcomes while treating the cancer. Prostate cancer screening to detect early-stage prostate cancer has resulted in increased identification of small volume, low grade, i.e. 3+3, prostate cancer, many of which meet the criteria for clinically indolent disease. Nevertheless, there remains some degree of underdetection of high-risk prostate cancer in substantial numbers of men, despite current diagnostic strategies. The objective of this talk is to discuss the contemporary role of the prostate biopsy, focusing on the indications, techniques, and limitations of current prostate biopsy techniques and evolving techniques affecting patient cure. In addition, Dr. Ukimura is introducing the new concept of focal therapy in prostate cancer. It is with great pleasure that the Prostate Forum of Orange County presents to you Dr. Osamu Ukimura.
Thank you.
Turn up the volume, Carson.
Thank you very much for kind introduction. So my name is Dr. Ukimura. So let's start my talk. So today's my talk including contents these 1 to 6. First, role and goal of prostate biopsy has now changed. And our new philosophy of imaging and biopsy service. And I want to talk about the new modern imaging, including ultrasound and MRI. And then such a MRI and ultrasound fusion image-guided biopsy. And further, a new technology of 3D mapping biopsy. And finally, I would like to introduce our initial experience of focal therapy. So today's talk is more summarized in this very recent my publication. I'm the first author, and these world expert pathologist and urologist is involved and critiqued me, and I many times changed my draft, and now I'm happy this sophisticated review article of prostate biopsy is now published in the most platinum journal in urology field just this year. So as you may know, this is a kind of section of prostate. You may realize this trajectory is the current indication of the first biopsy trajectory. Because not this, not here, is because this part is the growing part due to aging, that is named by BPH, benign growth of prostate hypertrophy due to aging. Only 20% cancer come from this new part, while 80% more aggressive cancer from this original prostate that is shown by white part. That's why the first screening biopsy is focusing on this original prostate, which we have teenagers. This part can growing up and then prostate going this big, but still this original part is staying the same volume which we have teenagers. And more history, that's why more cancer come from this original prostate. That's why screening biopsy is focusing on this. In repeat biopsy, that means after first negative biopsy, still if you have an elevated PSA, you may require another repeat biopsy. At this moment, we need to change the strategy because some cancer may miss in initial biopsy, therefore the repeat biopsy need to be targeted previously unsampled area, of course. Therefore, not only staying in this original part, we need additional sampling from this new part. This is the current standard version of initial biopsy and repeat biopsy. So that's the introduction of the very standard technique of biopsy. Now I would like to focus on my personal talk. So recent efforts toward early detection, mainly using a PSA, already has very well-known phenomenon, over-detection of small and low-grade prostate cancer happening. That means clinically insignificant cancer are overdiagnosis. Clinically insignificance is defined as no need treatment immediately. You can watch it. That means overdiagnosis. You don't need treatment right away. You can wait. Nevertheless, still, because there is a sampling error in biopsy, their PSA is not perfect. PSA is not cancer specific. I can tell there is 3 major reasons of PSA elevation. One is potentially cancer, but one is only due to volume of the prostate by aging. Thirdly, inflammation. PSA is just complex of these 3 phenomena: cancer, enlarged prostate, and inflammation. Therefore, need to be very careful to interpret the PSA, these 3 complex. Therefore, PSA is not specifically reflect the cancer progression. Therefore, need to be very careful. Therefore, PSA is not perfect marker, but most beneficial for the patient. It's still most important risk factor for prostate cancer. Therefore, still urologists and all over the world medical doctors using PSA. PSA is good. PSA is the best marker in the human beings, but still not perfect. Therefore, we still have an underdiagnosis of prostate cancer, even this PSA error. That's important. But more importantly, not talking only about the PSA, now we are talking about the biopsy. Because now I can tell the role and goal of prostate biopsy has changed. Used to be, it's just a pure detection of cancer. Urologists just interested in detect cancer in your prostate. I'm a urologist, but used to be. But now changed. From pure detection, now changed to assist you. That's important. To better characterize your cancer, whether it is clinically important or not. That's important. If your cancer is tiny and not be treated, I don't want to even detect it. I really want to detect important cancer need to be treated. That's what I want to say. Okay, now role of prostate biopsy has changed from pure detection to detect only important cancer. How to precisely identify important cancer? That's the main focus of my talk today. So indication need to be considered individual risk factor because PS is not perfect. And I need to know, when I'm talking to the patient, I need to know which is your goal. Okay? Indication of biopsy and management of prostate cancer is not perfectly from doctor's side. Now it's changed. Your side, that's very important. What is your specific goal? That's important. We need to think about when I do biopsy. So, current indication of prostate biopsy like this. Once you guys determine to undergo screening of prostate cancer using PSA, we're still using PSA as a best indicator, but we have no absolute cutoff of the normal value. That's important. 15 years ago, it was 4. Around 10 years ago, it's down to 2.5. Now, nothing. We don't have cutoff. You can tell. You cannot tell. We cannot tell. Your PSA is normal or abnormal because we don't have a cutoff. Cutoff value should be depend on our discussion between patient and me to determine what is your goal, what is your risk factor, including your family history and your current PSA, change of PSA, you have whether you have inflammation in prostate or not. These need to be discussed. That's very important. The critical dilemma is still we have no absolute threshold of PSA to determine high-grade cancer or clinically important cancer. Therefore, need to be discussed. There is a multiple risk calculator is now available in internet, such as European best calculator, SPS calculator, in US PCPT risk calculator. These two are the most popular risk calculator, including PSA, your family history, and your previous biopsy history, everything. Now I need to talk about management, because you need to have a knowledge of management option when you undergo biopsy. Because when you determine to undergo biopsy, if you have a cancer, what you should do? The knowledge of management option is a key factor when you determine to undergo biopsy. Therefore, you need to know what is acute surveillance, what is the standard surgery, what is the standard radiation, what is the new options such as focal therapy. Now, active surveillance is mainstream when you have a low-grade cancer. Therefore, you need to know what is the issues in active surveillance. Active surveillance is very good if truly you have a low-grade cancer. There is a most important randomized control study which is published in the New England Journal. That's the best journal in human beings. That's already proved. Active surveillance is as good as surgery if you have a low-grade cancer. Therefore, it is the most important decision. If you have a low-grade cancer, you can choose active surveillance. But still, there is a problem. That is a selection failure. Question of yourself is, really I have a low-grade cancer? No. It's depend on your PSA, more depend on the quality of biopsy which you had. If your prostate biopsy done was low quality, you cannot rely on it. That is selection failure. Therefore, quality of prostate biopsy is so important because biopsy is the final diagnosis to determine everything, what you should do. So difficulty in follow-up is also important because initial diagnosis is done biopsy, but follow-up also by done biopsy. Now, changed. Not only biopsy, now imaging is now added in sophisticated expert. But it's not yet standard. Therefore, I would like to educate you guys, not only biopsy, now imaging is now important, in addition PSA. If you have choosing active surveillance, anxiety may happen, and multiple biopsy-related side effects may affect to your quality of life. So these are the listed, but still issues, big issues, when you are choosing active surveillance. How can we improve it? Key is imaging and quality of biopsy. That's my talk today. So another new options of the low-grade or intermediate risk cancer is now focal therapy. Focal therapy is aiming to achieve both cancer control and preserving function. It's a dream because active surveillance is doing nothing. Even you are becoming a cancer patient, just doing nothing. Some patient doesn't want it because they want to treat cancer. That's why now focal therapy concepts show up. Because there may be a selection failure, there may be a surveillance biopsy failure. Therefore, as long as you becoming a cancer patient, subsets of a patient wants focal therapy. We believe it. So whole gland treatment and no treatment, between these focal therapy stands. So definition of focal therapy is selectively ablates known disease while preserving existing functions with the overall aim of minimizing lifetime morbidity without compromising life expectancy. But now, active surveillance focal therapy both are attractive, but there is a lot of challenge. That's why I'm working on for developing a meaningful protocol for both active surveillance and focal therapy. Because urologists, not me, conservative urologists against us, against our concepts, because we know prostate cancer is multifocal. Biopsy sampling is only 0.01% of entire prostate. Only 12 to 15 cores, it's only 0.01% or less. When we are talking about only biopsy, we cannot reflect the entire process, of course. Therefore, we cannot tell you have a multifocal versus single focus. Of course, we know such a limitation. Still, we won't, because we believe active surveillance and focal therapy have a benefit for you. Now we need to introduce index region concept. Even cancer is multifocal, here, here, and here. Do you want to find this or this, or only this? Our concept is we do not need to identify this kind of small, tiny focus, which is clinically insignificant. If we find this, it's overdiagnosis. But people against us is talking about these things, multifocality. This and this and this, that's a multifocal. But we are saying, we are more interested to find this one. We may not know, even don't know, this exists or not. But as long as we can find that clinically important cancer, we should be safe. That's the goal of the concept of focal therapy and active surveillance. Now, I need to introduce the new role of modern imaging. These decades, the technology of imaging changed tremendously. These two modalities is the most important imaging for prostate cancer. One is MRI, one is ultrasound. So as you know, grayscale ultrasound is the most historical ultrasound imaging to identify the anatomical change from normal and cancer. In MRI, anatomical imaging is named by T2 weighted imaging, very similar. But now you may know the Doppler study and now elastography. So Doppler study is to identify the vasculature because cancer likely need feeding the cancer cell, therefore need the vasculature. Doppler study can identify such a neovasculature to feed the cancer cells. So contrast MRI, contrast ultrasound or Doppler can identify such a neovasculature. Neovasculature is the key factors to progress the cancer. Therefore, if we can find the vasculature, that is more likely cancer, bad cancer. And also, as you may, this is probably new for you, elastography and diffusion imaging represent the cellular density. As you may know, digital rectal exam, that's the most historical diagnosis of cancer, to look at the hardness, hard nodule by rectal exam. That represents the cellular density because cancer cell is cancer is the mass of epithelial cell. Normal prostate consists of muscle and epithelium, therefore less stiffness, soft. If cancer is a mass of cell only, therefore it's hard. But finger exam only identify the posterior surface of the prostate. We cannot touch on the anterior. Therefore, imaging can help us to identify the hard nodule even in anterior part of the prostate. That's good. So finger exam is now replaced to the such a cellular density imaging. So these are the new imaging, very promising imaging. I need to talk about a little bit about the target biopsy. So let's say this is a cancer, okay? When we hit the center, it may be 7 millimeters from here to here. But same cancer, if we hit this, maybe not 7 millimeters, but 2 millimeters. It happens. If we can see this cancer by imaging, I can hit the center. But same cancer, if we cannot see the cancer, we may hit here or hit here, we don't know, even outside. Even if you have a cancer, same cancer, if the operator have a good image, we can hit the center, better characterize it. But if the operator have no idea of imaging, They may hit here or even outside of the cancer. Therefore, now imaging is so important. You understand? Another important technology we introduced, world first, is the 3D mapping biopsy. Even cancer is invisible. I want to know where it is. So this is a kind of technique, new technique. When I firing the needle in the prostate, I scan the 3D image. The needle is entering the prostate and scan the 3D image of the prostate. I document every single time, therefore I know where the needle is inserted into the prostate. These are all digitally documented. Therefore, after the biopsy, we can document where the needle is. Even I cannot see the cancer by imaging, this documentation of the location of the biopsy can tell me where the cancer is. Even imaging is not 100% perfect. Now we are able to document where the cancer is because I know which area is sampled. This is kind of new cutting edge technology. We are introducing this in clinical practice every single day. Therefore, we can develop such a trajectory in 3D space and we can tell which one has cancer. Depending on this, I can revisit the same spot 2 years or 3 years in the future when you have active surveillance, because I know where it was, your cancer. And also I can revisit the same spot of the non-cancer untreated, that is named bifocal therapy. This is active surveillance patient. First, initially, this and this and this and this was cancer, 5%, 30% involved. And 2 years later, I revisited almost same spot, it upgraded to 50%. And 5 was positive, because I know where it was. I can revisit almost same spot to determine whether that non-cancer progress or not, very precisely. So another important technology of biopsy is using MRI. Not only ultrasound, now we are introduced to fuse MRI data to my ultrasound. For example, this is the MRI data, and then you know this red spot is the cancerous suspicious, and then we do the ultrasound. This area is overlaid in ultrasound, that's the image fusion technique. And then I do biopsy 3D mapping. We are using even the MRI ultrasound fusion, 50% fusion, only using ultrasound image, only using MRI image, whatever. We can use any image that I want when I do biopsy. Case presentation. Not only the concept, I would like to introduce the case. This gentleman have a 60 years old man requiring repeat biopsy. Negative prostate biopsy in 2009 and come to see me 2 years later. This is a prostate coronal view, all benign 2 years ago. Come to see me and do MRI. And we found some suspicious in diffusion imaging. This is a higher cellular density and contrast. There is a cancerous lesion, and I really hit through that yellow lesion is overlaid. I really hit because my trajectory is documented, overlaid. I hit it and it was Gleason 60%. That means 1 centimeter lesions. Second case, he is on active surveillance. 2007, 4 years ago, he has PSA 5.1 and only 5% Gleason 6 cancer in left apex. 4 years later, he is coming to see me, and we did a MRI, and we found the suspicious area very anterior part of the prostate. and I hit it. Now it was Gleason 7, 90% of cancer, that means 14 millimeter in cancer length. Very dangerous. He underwent surgery in this case. Third case, again active surveillance. 2 years ago, he has a 5% positive and 1 millimeter and 1.5 millimeter positive in left apex and mid. And come to see me, and I did a multiple ultrasound, elastography, and this stuff, and I found the cancer now Gleason 7, 40%. Another case, this has just immediately before my biopsy, 2 months ago, he had a biopsy outside our institution, Gleason 6, 5% cancer. He really wants to own active surveillance, but he wants to make sure he's a candidate for active surveillance. And I did MRI, and I found the suspicious lesion. I hit it. It was Gleason 6, 40%. Not 1 millimeter. It's already 8 millimeter. So this happened because if without imaging versus with imaging, big difference. Because we can visualize it, I can hit the center, that's a big difference. Now I'd like to talk about focal therapy a little bit. This is the combination publication. You guys already familiar, Duke Ban and myself. Ultrasound, we identified the hypoechoic lesion and we hit the cancer lesion and we document where the cancer is. This is visualized, cancer is visualized and we are hitting the cancer in the center. Therefore, we can mostly rely on our biopsy quality because it is image guided and three-dimensionally documented. Still, you may not clearly understand the focal therapy and active surveillance. I would like to show the example. Because prostate is multifocus, this is supposed to be cancer, this is a cross-section of prostate, there is a multifocus. But focal therapy can treat this main index region because these are the biggest region, we need to treat it. But this tiny focus may be negligible, or even we don't know, we can watch. This is the kind of combination of focal therapy and active surveillance. Even prostate cancer may be multifocal. So this can be observed up to 5 years with safety of 100%, no life-threatening risk. Up to 5 years. So PSA is the kind of very difficult to interpret after focal therapy, but we found a very good result. Even after the focal therapy, we have found some role of PSA. Because our data shows before focal therapy, PSA was 6, around 6. If we successfully hit such an index region which is charged for your prognosis, PSA successfully down 70% from preoperatively. That means over 50% of PSA is come from index cancer. Therefore, such successful focal therapy can provide your PSA over down 50%. If we do not unsuccessfully hit the index and cancer, PSA may stay still 70% or higher. If we can successfully hit the index region, we already identify PSA down over 50%. This is the curve of our series, preoperative PSA, and 3 months, 6 months, 1 year, 2 years, 3 years. Because our treatment, focal therapy, have untreated area. This data is heavy ablation. One side lobe is treated, another side is untreated. Therefore, 1 year later, we are offered mandatory biopsy to make sure your cancer treated area is gone, untreated area, there is no important cancer. Therefore, we are offering mandatory biopsy after focal therapy. Because we know you may have a multifocal cancer, but we expect in untreated lobe, you may have a tiny focus, even worse. So actually we already found in untreated lobe, this is the, over time we found a clinically insignificant. Treated lobe, we have only one positive, that is treatment failure. That's good. Only one case out of 71 cases have failure in treated lobe. But untreated lobe, we can find a positive biopsy in untreated lobe. But all of them are clinically insignificant. That can be on active surgery. We can watch it. Therefore, our data is very good in selection. Probably we believe we are combining the imaging and image targeted biopsy. For example, how image works. So this image is explained bottom panel because not easy to interpret this image itself for yourself. So this part is the hypoechoic area with Doppler signals. This is a diagnostic. And then we are hitting, you may see this white line is the biopsy needle. Actually we hit the center of the region, therefore very reliable. This is where the cancer is, we know it. Another case, this is the hypoecho region here and Doppler signal is corresponding, therefore it's highly suspicious. In another view of this is seminal vesicle, this cancer look like involving to seminal vesicle. If the cancer is extend to seminal vesicle, it's a high risk cancer. So we are hitting seminal vesicle and to identify seminal vesicle involvement. This is not good candidate for focal therapy. So such a preoperative successful selection is the key to successful focal therapy. Another case, this is the hypoechoic region with Doppler signals. We hit the center of the region, therefore we know this is the cancer. Again, this is a pretty anterior part that is unlikely hit by regular use because the needle is firing from the posterior surface to it. So if it's always the biopsy is hit here, they cannot reach to anterior part. Therefore, if cancer is visualized by imaging, the cancer is located anteriorly. We are firing the needle. First, we are placing the needle up to here and then fire it. Otherwise, anterior tumor cannot be identified. So imaging can tell us, you should not firing from here, you should firing from here to here. Otherwise, anterior tumor unlikely be defined. So this is a prior case. There is a region Doppler signal identified that corresponded, and we hit the biopsy. And then we did a prior, and you may realize this right lobe is shrink too much. Not too much, shrink very much. That means this right lobe is treated. Your immune system now realizes because the right lobe is treated. Your immune system now realizes that area is enemy. Used to be right side and left side both your cells. Therefore, your immune system does not realize which is the bad, which is the good. Once treated, the cell membrane is destroyed, your cancer antigen is exposed. Now your immune system realizes, oh, these are the bad guy. This side is still good guy. We are biting it, and it is absorbed and disappeared. Such a immuno response can be enhanced by cryotherapy. So another case, this is a lesion, this is the Doppler signals. Again, we are treated this lobe. You may realize this left lobe is shrinked because the immune system binded and disappear these regions. That's good sign. So this imaging can help us the successful treatment, and also preoperative PSA and postoperative PSA can help us. We are really hit the index region, therefore the PSA down over 50%. Now conclusive slides. New era of prostate biopsy has come. Considering individual risk factors and patient-specific goals. Used to be, we are only interested in detect whether you have cancer or not. Now we change it. Not only detection of the cancer, we need to characterize the cancer to provide you more benefits. For your benefits, we need better characterized cancer, and we want to know where it is. We want to know whether that cancer progress or not in the future. Modern imaging such as multiparametric MRI, multiparametric ultrasound can better characterize and localize cancer to allow precise targeting. That is significantly better than simple PSA screening with just image-blinded random biopsy. So now, we are proposing a new concept, not patient prostate-based active surveillance. Now we are focusing on lesion-based. We know where is the lesion. Right side lesion, bad. Left side lesion, okay. Now right side lesion need to be treated. Left side lesion can be watched. Such a lesion-based active surveillance and focal therapy is now available when we are using best imaging and high-quality biopsy technique. Thank you for your attention.
Thank you, Dr. Ukimura. What we want to do now is have you stand about right here. Or no, stand up there and we'll take questions from the audience. And I'll give the microphone to whoever wants to ask the question. So let me see hands of anybody that wants to ask a question right now.
Oh, I'm very impressed with this, and it's very thrilling. I just want to know what stage it's at this point in terms of availability to us.
So, specifically, you are talking about...
Can he get it now, or does he have to wait 6 months?
Are you the only one doing it, or...?
Duke and me is, I believe, same level.
What do you predict as far as becoming more widespread?
Because they need to experience in imaging. Because Duke is radiologist.
Yeah.
I'm urologist.
Yeah.
But I'm expert in imaging. That's why I can make it. I learned from him, but basically I'm a urologist, but there is an interesting story.
It sounds like cutting edge.
It is cutting edge, but the education of imaging is the key. But radiologist is an expert of imaging. That's why Duke make it. But I'm a big experience of imaging because my first mentor is actually the innovator of transrectal ultrasound in 1975. I educated by him 10 years. And actually Duke's mentor is friend of my mentor. So we are friends. That's why we have a lot of experience in imaging. But now education of imaging the key, because prostate imaging is now evolving these decades. Therefore, over 10 years ago, urologists have no idea how to use the prostate imaging. They are just using ultrasound to hit prostate, not cancer. Hit the prostate. That's the aim. Now, time changed. Now role of
I got
ultrascience.
that from what you said.
So therefore, we are still struggling to educate the people. We are now conducting the postgraduate educational course in AWA. AWA is the American Urology Association, the biggest association, academic association in America. We are now conducting the educational course of ultrasound, educational course of focal therapy, educational course of active surveillance. We are talking an image. We are talking the new technology of biopsy. So subsets of the urology very interesting because they believe this kind of is the future. Currently, robotic surgery is so expanded, but now everybody, especially patient, know that may be overdiagnosis, overtreatment. So now, avoiding overdiagnosis, avoiding overtreatment, we need focusing on active surveillance and focal therapy using breast imaging. Yes.
Thank you, Dr. Fulmer.
Yes.
At USC, when you do imaging and you find, lesions, and, are you able to quantify the volume of the lesion, or do you use the diameter of the lesion? And how important is the size of the lesion?
Are you radiologist?
What?
Are you radiologist?
No, I'm just trying to survive.
You are you give me a very good questions, even the.
Well, actually, I'm being treated
Okay.
by your
So
colleagues.
volume measurement.
Anyway, how important is volume or diameter in determining, how the lesion will, how the cancer will progress?
Very good questions. Okay. So we are trying, but not reach to 100%. But imaging is now going to better and better to more precisely measure the volume. But estimation, underestimations to happen. Okay, imaging is actually granular level, not cellular level. Cell is 8 micron. Okay, cell is 8 micron. Imaging can identify millimeter level, not micron level. Therefore, of course, imaging have overestimation and underestimation happen. But once target biopsy hitting, now it's micron level. Understand? Therefore, imaging, when combined with biopsy, now it's estimate more precise volume.
Could I
Therefore, not only imaging, we need combined with targeted biopsy to hit the center to get the micron level data set.
Okay, let me ask.
Yes.
Okay, say someone has, a lesion, and then there's a biopsy. Like in my case, I actually, this occurred with me. I have, one of my lesions is 1.5 centimeter diameter, and there's a 3, low volume 3+3 on one side of it, and then there's also a low volume. There was two opinions. One was 3+3, and the other was 3+4, also very low volume. So does the entire lesion, does this biopsy affect the entire lesion, or is it just that part, or how does that work?
So that the biopsy is done by targeted biopsy or not? That's the main question.
There was a targeted biopsy.
So if it is visualized, we know that is hit the center or not. And if it is really hit the center, you can rely on that.
Well, it was, I don't know exactly, it was on one side or the other, but, what I'm saying, if you hit a biopsy, which is millimeters, and the lesion is centimeters, so is the biopsy indicative of the total lesion, or is it indicative of just that spot?
So that's the most important questions. How precisely target the center of the lesion? That's my main question to your doctor. Really,
I ain't no doctor. I'm a patient.
Okay, but question is, let's say if cancer is this shape, if hit the peripheral part, maybe 1 millimeter. If I hit the center, maybe 10 millimeter. So if it is visualized, no question, we need to hit the center, right? So that if it is really visualized, the doctor must hit the center, and he can hit the center. But if not visualized, he may hit the peripheral part. Even cancer is 10 millimeter in diameter, the biopsy say 1 millimeter. It's happening clinically. That's why image targeted biopsy is very important. Such a quality of the biopsy is now important. Therefore, even after the biopsy, you may have a benefit to visualize the cancer afterwards to estimate which is a cancer. And if you have some curiosity, you may ask another targeted biopsy only, not 12 or more, just hit the center one course, less invasive, and get the more precise data set to determine your decision.
Thank you.
Yes.
Is your biopsy done real time with the MRI?
No. MRI is the previously acquired. That data set need to be fused with real-time ultrasound. So real-time imaging for biopsy is ultrasound. MRI data can be fused to ultrasound. Yes.
Anybody else? Yeah. Here you go, sir.
Is this available now to be referred to you or to your colleagues who are working with similar techniques? And do you have to know also if insurance covers it at this
Correct.
point?
Insurance covered. Yes. So MRI sometimes covered or not based on the insurance, but this 3D image-based mapping is totally all insurance covered. It's a regular biopsy. Just I'm using 3D ultrasound. That's the difference. So all insurance cover my biopsy.
Dr. Dupont does the cryoablation focal. What technique do you use for your ablation?
Cryo.
And you use
Because only currently cryo is FDA approved procedure. There is several other modalities such as high intensity focused ultrasound named by HIFU, laser, and some photodynamic therapy. All has not been approved by FDA. Only cryo is historically already approved. Therefore, I'm focusing cryo in US. If you are interested in some other modality, you may go Canada, you may go Japan, you may go Mexico, you may go Europe. Please ask FDA guys, please approve as soon as possible.
Okay, is it possible along the way that the focal therapy ablation will come from radiation or surgery?
Brachytherapy is now kind of interesting. They are interested in focal therapy because brachytherapy is just seeding the radioactive seeds in the prostate. Historically, whole gland prostate is the target, but potentially they can seed only non-cancer area. Of course, that's the name by focal brachytherapy. Conceptually, it is available, but in US, very rare people doing. In Japan and Europe, they are studying. Because urologists doing brachytherapy in Japan and Europe. In US, I believe likely radiologists doing brachytherapy. So they are a little bit behind about focal therapy. Urologist is more ahead in terms of focal therapy.
Thank you. Anybody else have any questions before I wrap it up? Okay. Now I know historically, Doctor,
Yes.
that these gentlemen do have their own private things that they would like to talk to you about. We do like to tear down the equipment here and get you your stuff and get ready to go. So if you could just step back here behind Charles, behind the camera, and let anybody that individually wants to talk to you for a few minutes say, I know there's going to be some individual questions there. Just a minute, Dr. Ukimura. You know, we don't have a lot of money at the Prostate Forum here, but we know a doctor's time is his money. So we have something here to save Dr. Ukimura some time. This is a coffee cup that sits right in your car so that you don't have to drink coffee in the kitchen. You can save the time drinking your coffee. Thank you very much, Dr. Ukimura.